Let's talk about the first aspect of the appointment. The first part of the appointment is seating the patient. I don't think we need to talk a lot about this section, but we do need to address some things. I care a lot more about time than I do about a patient's time in the chair. However, efficiency is efficiency to some degree. Here are the things that I care about. I care about the patient being seated on time. From a patient experience standpoint, not many things are worse than seating the patient late. Well, maybe some things are worse, but this gets the appointment off to a poor start, and you don't need to make the patient annoyed in the very beginning. You don't want them annoyed before you even do any of the hard things. So at all costs, the patient must be seated on time. And this counts for every single appointment. If the patient is still filling out a medical history, I don't really care. Just grab them and seat them. They can fill it out while waiting for anesthetic, during other downtime, or after the appointment. Do not allow medical histories or things like that make you late. The assistant needs to do all of the normal things like reviewing the treatment for the day, getting consent signed, and making sure the setup is ready to go. I also want the assistant to do as much of the anesthetic process as possible to minimize what's needed when I come into the room. It's not that hard to teach your assistants what kind of anesthetic you are giving and in what situations. I will put together some type of a guide to help with that, but every assistant needs to know exactly what you're going to inject, how, and where for any given situation. The next thing is I want the assistant to get everything ready and put the topical in the mouth. The moment that topical is in the mouth, the assistant can find the doctor and tell them they're ready. Some doctors don't use topical, and I think it's more of a patient experience show thing than actually being super helpful, but it does make somewhat of a difference. You can get into the super high strength topical, but I'm not sure that juice is worth the squeeze. I've tried it, and the potential complications, hassles, and training, I'm not sure it makes enough of a difference for me to do it. Teach your assistant where and how you will inject, and then teach them to dry and place topical appropriately. It really should not be a big deal. If it takes a few extra minutes for the doctor to get into the room, it's not a big deal. The topical sits a little longer, and all of this is 100 times better than coming into the room, having to place the topical yourself, and then just sitting in that room and waiting. You should never be waiting. It should make you very uncomfortable, and you should try to minimize this as much as humanly possible. When I come into the room, I have the assistant take out the topical and do a quick rinse. I will say hi to the patient, ask if there's any questions, and then just start injecting. After that, I let the patient know that we want the anesthetic to take full effect, and we'll let them hang out for a while as that happens. And this is my time to do exams, catch up, or do what I need to do so that when I come back into that room, I can focus on those fillings. Now, none of this part is novel, I get it, but a percentage of dentists still need to hear this. If you don't do a lot of hygiene exams and it doesn't make sense to wait for a while for anesthetic, maybe in the future I will do some courses or training on techniques that can allow you to get working right away, but this is probably not worth going into at this moment and probably won't be the case for you. Let's talk a little bit about the different types of anesthetics and the pros and cons of each for a moment. I'm using this info from a bunch of different studies, but a lot of the studies are really all over the place. This should be pretty close though. Lidocaine 2% with 1/100 epi is super common. Its onset time is 2 to 4 minutes for infiltration and about 5 to 7 for blocks. It'll give you about 60 to 90 minutes of pulpal anesthesia and 3 to 5 hours of soft tissue anesthesia. Then you have articaine, 4% with 1 to 200 epi. It has about the same onset as lidocaine, 2 to 4 minutes for infiltration anesthesia and 5 to 7 minutes for blocks. Duration, according to literature, is slightly longer, like 80 to 120 minutes for pulpal anesthesia and 3 to 6 hours for soft tissue anesthesia. And now we have mepivacaine, 3% plain. It has the same onset time as the others, but the duration is way shorter. It's got 20 to 40 minutes of pulpal anesthesia and 2 to 3 hours for soft tissue. Obviously, no epi with this one. And then the other one we'll talk about is bupivacaine, and that's 0.5% 1 to 200 epi. This is slower and takes effect in 6 to 10 minutes and has a duration of 90 to 100 minutes of anesthesia. These are the main types of anesthetics used and a few of the base details about them. Now that we're on the same page about this, I will go through just a basic anesthetic protocol that I use. This is simple, but if you need a starting point, this would be a good one to follow. So infiltrate with 1 carpule of articaine, 1 to 200 epi, for anything other than lower molars. For example, if you have a quadrant of fillings on 12 through 15, I would do 1 septo between 12 and 13 and 1 between 14 and 15. That works great. Use a similar strategy on the lower. If I have lower molars involved, I will block. For a standard block, I will do 1 carbocaine and then 2 lidocaines. And I'll do this every time. Now, I laugh when I watch dentists do a block with 1 lidocaine. They may have some magic sauce, but I don't see how anyone can really make that work consistently. If you can make it work, please make a video and message me because I would love to learn. You should be able to have at least a 75 to 80% success rate for blocks with that first stage. If you are lower than that, then you probably need to review your technique. I might make a new video on that shortly to help. But if the block is not perfect, I will do 1 articaine in the block and then infiltrate half buccal and half lingual to try to take care of any accessory innervation. That works almost every time. For extremely rare cases outside of that, I will do an intraosseous injection. The only other variation is that when we are doing surgery, I will use more bupivacaine for the longer duration just to help keep them comfortable for as long as possible. For fillings, I am never using it. There are lots of variations to try, but this is tried and true and will give you consistency. Feel free to adjust and experiment, but this will start you in a good place. After injection, I will take 10 minutes to do exams and any other quick things that I need to do. It is a good spot to work in ERs or post-ops as well. For infiltrations, I know that I can start as soon as 5 minutes, and I will usually leave it around 10 minutes for blocks based on my experience. Now, I hope this helps you from an anesthetic standpoint. If you are getting results worse than this with your technique, you should switch. If you are getting better results, hey, message me or comment below. I love learning and trying new approaches. Thanks for watching, and let's keep working together to make dentistry more fun, rewarding, and fulfilling. Don't forget to subscribe and stay tuned for more.